Good evening, everyone. Welcome to Rehabilitation Science's YouTube channel. We are here again with a very interesting topic, neurorehabilitation, neurorehabilitation unlocking potential, and the battle with multiple sclerosis. And we have faculty today, very senior physiotherapist and very known face, Dr. Jasmine. She'll be talking about this topic. Dr. Jasmine, we would like to have your consent for making your lecture on YouTube Live, ma'am.
Yes.
Yes, thank you, ma'am. Thank you so much, ma'am. And moderator today, Dr. Sagun Agarwal, he'll be formally start the session. Dr. Sagun, you can start the session set now.
Thank you, Dham sir. Good evening, everybody. Welcome to the Rehabilitation Science Group. Today, we are having a very senior physiotherapist with us, Dr. Jasmine Anandabai. Ma'am is currently officiating principal in Subhati College of Physiotherapy in the Swami Vivekanand Subhati University. Ma'am has did her master's in physiotherapy in neurology, PhD and MD. And ma'am is also the advisor in MSSI Delhi branch. We welcome you, ma'am, on Rehabilitation Science Group channel. Thank you for giving your consent.
Thank you, Dr. Shagun, Dr. Dharam Pandey, and Dr. Harpreet. And I'm really thankful to you three for all this, for giving me this opportunity to share what I have learned in all these years. And since multiple sclerosis is a topic which is very close to my heart and a topic not very much seen by many people, uh, since they have a multiple sclerosis society in Delhi, and I'm a part of that society, and I have been working with them since last many years, and they're doing a very good work with these patients. So I want to share some views of mine about neurorehabilitation in these patients, and patients who are battling with multiple sclerosis, our physios who are looking after such patients, that how we can unlock this potential. So when we talk about multiple sclerosis, it is basically of four types. It is very important to know these four types, because depending on them, there depends the unlocking of the potential of the patient, how well you can treat the patient, how well you can rehabilitate the patient. The first is relapsing remitting. As it is written that this type of multiple sclerosis has periods of new and worsening symptoms. There are relapses, and each relapses is followed by a partial return. So that means every time they have a relapse, there is a bit of worsening, and this keeps on increasing till there is a compromise in the functioning of the patient's level of work AD, and this is also the remission period. And it was the first form of MS which was diagnosed. Then there is the primary progressive type of multiple sclerosis, which is a slow, continuous process. There's gradual worsening of the functioning from day one, from the time of being detected. And there are no relapses or remissions, but there is continuous worsening, which is very slow. Then there is secondary progressive, which begins with the relapsing remitting type of multiple sclerosis. But this develops into a steadier progression of disability. Since there are no relapses, but it is continuously, and there is a steady progression of the disability. And then last is the progressive relapsing, which is again slow, but there is a continual worsening functioning from the beginning. And along the way, there are occasional relapses. So, first and foremost, it is very important to diagnose which type of MS the patient is suffering from, because this will set the course of the treatment and the goals that you have to achieve. There are so many symptoms of multiple sclerosis, and they vary from mild symptoms to very severe symptoms. Symptoms in everybody is different. There are vision problems, cognitive problems, bladder problems, muscle weakness, numbness. All these are some of the symptoms, and again, they may be very mild or very severe. The patient has bladder problems, bowel problems, depression, psychological changes are very important, which are least addressed in our society here in India, and difficulty in walking or balance, fatigue, and some other symptoms which are nerve pain and paresthesia. which can manifest itself by showing as sensation of burning or only coldness, heat, prickling, numbness, itching or tingling. It can be one or all together or a few of them together. Then problems with cognitive function, that is thinking ability, and also the memory, which has to be addressed. These patients have a lot of sleep problems. They may have spasticity. Spasticity is that means stiffness or uncontrollable shaking of the muscles, speech and swallowing problems, tremors, vision problem, as I said earlier. So these are few of the symptoms. And again, as I said, they can be very mild or they can be very severe. Various effects of multisclerosis on the different, as we have already talked about, difficulty in walking, person who becomes unable to walk or drive can even lose their jobs or their livelihoods. And then the more they become less mobile because of the weakness, so there's greater, more risk of having complications also. So what is the treatment? Everyone is saying when you talk about MS, the first question that arises from the patient is, what is the treatment? What is the advancement in treatment? Like again, when I said we are looking about a different issue, we are unlocking the potential of the patient. Mostly MS treatment, everybody knows it has either prescription drugs or the rehabilitation. And these are the main pillars of the treatment of MS. And it has to be together. One cannot function without the other, and they're both dependent on each other to have a good quality of life. The main drives of drug therapy available is disease modifying therapies, which helps slow the disease progression, or symptomatic therapies, that is, they do not affect the disease course, but they help in the relief of the symptom. And very important to know, MS is a disease which is lifelong and no known cure. This is very important that it is accepted, and hence whenever there is a relapse, whenever there is an attack, the rehabilitation should not be stopped and the patient should keep on taking the treatment. Many types of rehabilitation therapies are there, which are being used for treating multiple sclerosis. And some of the examples are physiotherapy. Physiotherapy applies respiration therapy or breathing therapy, exercise, balance therapy, cognitive rehabilitation, use of devices or adaptive devices, cooling garments, and physical therapy in itself is a huge area which can be used for treating MS. They use various different equipments. They use uh, uh, bands can be used for exercises, weights can be used for exercises, self exercises can be taught, other ball exercises can be done, manual therapy is there. So it's a whole huge area in physical therapy. And there is no such thing that only one thing is important. All of them are important, addressing the various issues like we talked in the symptoms. According to the symptoms, that patient has to be treated. Speech therapy is also important because if a patient is not able to communicate, then that also becomes difficult, and it's a two-way process in healing. And occupational therapy, we can't ignore it. It's also part of the rehabilitation therapy. Now, every time it is asked how to manage the symptoms that the patient is suffering, and what type of rehabilitation therapies will help. So there are evidences, and when we talk about evidences, moderate evidence shows that 8 weeks of therapy at home or outpatient therapy, that is, the patient is going to a department or a clinic or to a therapist, and that can help improve balance with regular exercises, disability, and also the gait pattern or the walking pattern. Weak as evidence shows that 6 weeks of cross specialty outpatient rehabilitation, going into different rehabilitation techniques, can help improve just disability and a bit of function. So this is a weak evidence. And what we have to focus on? We have to focus on minimizing the effect, the impact of the disease. The disease impacts in different ways on different people, and there can be effectiveness of exercises, the different exercises which are told to the patient. A program is designed for the patient in rehabilitation, the patterns of exercises which are being used in that program. Most importantly, these patients have to conserve their energy. If they do fatigue, then there is more chances of relapse, and also the environmental conditions which are very important for them. Again and again, it has to be emphasized. The two keywords are no fatigue and no heat. This should be kept in mind whenever we are talking about multiple sclerosis. Heat will cause relapses, increase of the symptoms. Again and again, patient goes through the same cycle. So cooling is very important, and this is goes hand in hand with conserving the energy of the patient. So energy has to be conserved to be able to perform their activities, live a normal and good quality of life. Pacing means that pacing of the activities, pacing of the various events in the day or in their life events. So it is also to be addressed. Then also, to minimize the impact of the disease, the tools and techniques which are applied to simplify the task of their daily living and occupations if they are working, is very important. Unless we identify these tools and have an appropriate technique for simplifying these tasks and the daily occupations, we cannot minimize the impact of the disease and have a better quality of life for the patient. What we need to know is that by applying precise approaches to multiple sclerosis, which aims firstly to identify the progress of the disease. Like we talked earlier in the first slide when we were talking about the various types of MS. So when we talk about various types of MS, that will identify the anticipated progress of the disease. What the patient has to expect as they progress with the disease, and exactly from the start. There is no this thing that okay, we are walking now, we are fine now, we have been diagnosed with the MS, the patient has been diagnosed, and if you take it lightly, so it will be a worse prognosis. Then it has to be predicted which are the treatments which are most successful. What is most successful treatment to be applied to that patient? Is it some form of strengthening? Is it balancing exercises? Is it strengthening exercises? Or some other areas? Are there visual issues which are hindering in the progress of the patient? Are there other bladder and bowel issues which are causing psychological impacts, or any other issues which have to be addressed? Even the caregivers or the families, because it's a disease of the family. When one person in a family is affected by MS, it is the whole family which is affected. And then again, advanced treatment approaches have to be addressed and decided from the beginning only. So these advanced treatments are changed according to the condition of the patient. What is the current evidence? The current evidence says first, what is MS? It is a disease of the central nervous system. What happens? The immune system attacks the brain and the spinal cord. As we all know, the central nervous system is the brain and the spinal cord. The nerve sheet is damaged. The myelin sheet of the nerve is damaged. And what happens when the sheet is damaged? There is affected the signals that are carried from the brain and spinal cord. These are affected, and these are the signals which cause all the symptoms. So as you can see in this picture, the myelin sheet is affected, and the signals are either slowed or blocked. And these are signals which are being transmitted from the brain to the body. And when there is healing, there is multiple scarring, and this scarring is which causes sclerosis. So they are multiple, so this is called a multiple sclerosis. So it's a degenerative disease which attacks the central nervous system. The cause is unknown, but research points to interaction of the genetic style, genetic condition, the lifestyle, and very importantly, the environmental factors. When we talk about environmental factors, it is a disease which is seen many times in cold countries, but now it is everywhere. It is rampant. India also, we have a lot of patients. India, there is a multiple sclerosis society dedicated only to India with various chapters in the various cities of India. I am associated with the Delhi chapter of the Multiple Sclerosis Society. So this evidence, what this evidence says for the different type of rehabilitation therapies or the exercises or any program of physiotherapy that we give to the patient. There is moderate evidence which says weekly home physiotherapy or outpatient therapy of 8 weeks. If it is done, it can help in balance activities, improve the balance, improve the gait. But it is not likely to help in the upper arm function or activities. But there is very weak evidence of the other things, that is comprehensive 6 weeks outpatient rehab, or only motor and sensory balance training of 3 weeks, or only breathing exercises of the upper extremity, or only inspiratory muscle training. So these do help with some of the symptoms like disability in function, or balance and dynamic balance, or static balance, or walking. But these are all weak evidences. This has been seen in the various studies done on MS. And there are a lot of studies and researches going on, which is the need of the hour. And a lot of information is still needed on what is the time, length of time needed for activity. Patients still believe that if they do an hour of exercise, it is much better. But like I emphasized, that fatigue is one of the important factors other than heat. So activity means exercise or any type of activity. So activity is not different from the type of exercise program which is given. If a patient is doing an hour of exercise, but again they are doing other activities, going to office or doing housework or any other activity, it all causes the use of the energy. When we talk about conserving the energy, so what is the length of time needed for any activity, for any exercise program? Then what is the intensity of the exercise? Heavy exercises, maybe treadmill, or light exercises. Light exercises can be simple movements, simple range of movement exercises, or intensity may be heavy strengthening exercises. Again, it depends from individual to individual. No two patients are similar, nor are their needs similar. Each exercise program has to be designed individually. Now, what is the outcome of the function? This is also important. Ki, do they have a good outcome? Is it worth putting all those activities or those programs? Will it cause a good outcome? Then again, if there is a good outcome, will it last? We can make a patient walk, we can make a patient stand, but then for how long? If we conserve, if we have a paced level of activity or exercise program, so that will have a more better benefit, instead of making the patient walk and after a few days they are unable to conserve the energy, the fatigue is there, they have relapses. Then again, how long should these therapies continue? It is a lifelong disease. Like I said, there's no known cure as such, and they have the drug therapy as well as the rehabilitation therapy, and it should be continuous. Continuous doesn't mean that every day of therapy is needed. A program has been set out, individualized to the person, which addresses their needs. How many times a week, or uh, how many days a week is it to be done daily, or maybe 3 days a week, paced with other activities. If they're going to office 3 days, so the days they're home, when they conserve the energy, then those days can be used for giving an exercise program. And then how many times this therapy has to be repeated? And if it's possible to have a group therapy, because group therapy, even if done once a month, is very good for the psychological aspect of these patients. And there are a lot of variables. The variables are the other neurological disorders. A person with multiple sclerosis may have a spinal cord injury, or a brain injury, or stroke, So there's no fixed deficit when we talk about multiple sclerosis. And all the variables are the symptom profile, what type of symptoms the patient is suffering, the activity of the disease, whether it is relapsing, progressive, slow progressive, MRIs, the various MRIs may show the new lesions, and all these are burdens of the variables. And therapists should be prepared to treat each patient individually with flexibility. They should have a flexible exercise program throughout the course of the disease. Like if a patient is going through the acute phase, so there should be a flexibility to reduce the amount of exercise or the exercise program. Most importantly, we have to focus on the quality of life. Most of these people are diagnosed as early as 20 years and as late as 50 years. And as if we talk about a 20-year-old, they're at the peak of their career. They're starting to go into life. I have seen people who are studying and they have their whole career, they're planning on the career, and they're diagnosed with multiple sclerosis. So, or people who are at the peak of their career, they have their responsibilities and they are unable to cope up then because they have to fulfill their responsibilities. And if it is the early years, there is females have a childbearing years also. However, MS can also occur in teens and older adults. Although there is a slight reduction in the life expectancy for people with suffering from MS, but the quality of life has to be improved. They have a good life expectancy, and we have professionals will attend to the need of these people and also the older population with MS. There is no set protocols or time limits. It's a unique opportunity to employ the numerous skills that we learn over our years in our course of our profession, and the various interventions and the various resources available and which can be given and shared with the patient. Because MS is, as I said earlier, is not a disease which affects just an individual, but it is a disease which affects the whole family. And this disease, it benefits if there is a team approach. Team approach means the caregiver, the family members, and also the individual. It cannot be done that, okay, now they have MS, so their life stops, they should be put into one room. People don't have time to look after them, and um, uh, people are unable to give them proper care. Now there are so many resources available. Like I said, in all big cities, the society is also there, and they do a lot of charitable work also and help a lot of people. They have regular meetings with them, they have regular updates with them, and they are even giving them good physios at a very reasonable charges. So this is something which has to be the individual and the family has to take full um, uh, involvement in the rehabilitation of the patient. Then coordination and communication with other health providers is also extremely important. Now there are periods of expiration. What is expiration? Expiration is a time period when there is a flare. The disease comes back in a full flare acute stage. With this versus the pseudo, it's a pseudo exacerbation also. When there is an actual relapse or flare or attack, there is new symptoms or a worsening of the symptoms which last as much as 24 hours. And these symptoms are usually associated with inflammation, more spots of demyelination in the central nervous system, even in the optic nerves, and they are separated from the last relapse or the flare of the symptom by at least 30 days. Now, if there is a pseudo attack or pseudo exacerbation, there is a temporary flare of the symptoms which lasts up to 24 hours. When there is a relapse, there is at least 24 hours, but here it is only up to 24 hours. Now, these symptoms, they are not associated with the central nervous system inflammation or the damage to the central nervous system. And like I said earlier, there are possible triggers, things which will trigger the course of the disease, and most importantly is the core body temperature. So it is very important to keep the body cool. The body temperature should be cool. So that is directly proportionate to the amount and the time of exercise also. Because any form of exercise raises the body temperature, core body temperature. Heat or humidity during exercises, bladder or bowel fullness, and or stress. Stress is also a very important factor. If somebody is stressed out, so the symptoms will flare up. And then it can be a temporary flare up. And these symptoms basically return to baseline when the trigger is minimized or eliminated. If it is because of the heat, if there is cooling of the body, so the symptoms will subside. When we talk about neurorehabilitation is not only physiotherapy, but also a combination of two processes. These two processes are adaptation and the alteration. The adaptation of the disability to the disability. A patient is unable to walk, so they can be given a prescription of an appliance to help them, maybe a appliance to help them eat or do their activities, or an appliance to make them mobile, which can be a wheelchair or a cane or a walker or a brace. Again, these appliances should be used regularly by the individual, because this will also lessen the burden of the activity, and the patient is able to conserve their energy. Now, alteration of disability can be a natural process or by the manipulation of the physical abilities or the anatomico-physiological structure of the differently abled person. So this is what neurorehabilitation does. There are some key elements and priorities for physical therapy interaction in the different phases of the disease. It has to be identified what stage of the disease is. Is it at the time of diagnosis? I'll be talking about the different stages now. So if it is at the time of diagnosis, why an intervention or an interaction of the physical therapist is required? It is required firstly for the education of the patient. By educating the patient means that the role of the physiotherapist or physical therapy is explained to the patient and the caregivers or the family members, so that the patients remain active, mobile, safe, and comfortable. A thorough examination, physical therapy examination and evaluation is done to establish the baselines. It is on these baselines that the whole program will rest. It is important to identify the physical abilities and the areas which need improvement. On that will be based the exercise program or the rehabilitation program. Rehabilitation program is a comprehensive program involving all rehabilitative therapy. A realistic goal has to be set. It cannot be done. A patient is unable to sit up, unable to walk. So what we have to do is make them, mobilize them, maybe in a wheelchair. So all the expectations or the goals should be very realistic and step by step. That doesn't mean a patient who's not able to sit cannot stand, but it will take time. So every time a goal which has to be settled should be realistic. So first, if it's the patient is only lying, not being able to sit for a long time, so the first goal has to be sitting. And after sitting, it can be standing, and thereafter to walking or any other activity. And this is very important when we are setting the goal and the expectation. Our emotional support is very important, because that is what gives strength to the patient and the family. With the emotional support, anybody can do anything. The frame of the mind is very important. Now, when initiating care, it may involve evaluation and few follow-up visits. Initially, just an evaluation is necessary and just to guide what has to be done, because at the first time, at the time of diagnosis, the symptoms may not be severe, they may be minimal, mild, and a few follow-up visits. Why are these visits important? What happens is the patient goes, gets a sitting of physiotherapy or a consultation, and then they don't follow. They wait for the next attack, which may be a few months, a few years, or many years, and then they go back to look for help or a consultation. So they can be very infrequent, maybe once a week or once a month, maybe just 2, 3 visits a month, just to monitor the exercises they have to do, Once it is diagnosed, that means the MS is there and it will be slowly or progressing depending on the type of the disease. So the monitoring of the exercise is very important. Also, when there's regular consultations, visits to the therapist, so there is a adherence and assurance of the adherence to the program, and there is also progression of the exercise depending on the condition, which may be better or worse, and it can be modified. At the time of diagnosis, first we said education and through physical examination and evaluation. Then also through a exercise and physical activity program. Now, evidence-based exercise and physical activity program has to be given to the patient based on the patient's evaluation, the interest of the patients, and the access to therapy or that the patient has. Also, emphasizes has to be laid on the importance of regular exercise for successful management of the disease and for having optimizing the good health. So, what is important? Avoid fatigue, conserve the energy. Now, there are some periods which are periods of stability. At the time of disease, we have talked what has to be addressed. Now, during periods of stability, during periods of stability, it is important to monitor and for regular consultation. The therapist, when there is regular visits, they may monitor the mobility of the people with MS, even during periods when there are no clinical or radiographical disease changes. MRI may show no changes. Clinically, there may be no changes, no progression. So the physical therapist is able to monitor by seeing the minimum, by evaluating again and again. If there is a sign, there is slight weakness, which the patient may be using a trick movement, but since they are not having no problem in the activity, they continue with it, and by the time they come back, it is in a condition which cannot be, not much can be done. So this is important to be monitored. Then consultation. The patient should consult the therapist every 3 to 6 months minimum. We don't say every month. Have a therapist go and consult once in at least 3 to 6 months, which is not asking too much. And this will also assure that they are adhering to their exercise program and they are the physical activity recommendations which has to be given, and also the various appropriate modifications which has to be done to the program. Then again, during periods of stability, like we say, checkups. We go for regular health checkups. Even a normal person goes for checkup. People diagnosed with cancer or other diseases go for regular checkups. People with paralysis go for regular checkup. Similarly, these people have to go to their therapist for regular checkups, or they may be even called as tune-ups, tuning up your body, because it a session will include the assessment of the strength of the patient, assessment of the balance, assessment of the flexibility, and not to forget the cardiorespiratory abilities of the individual. These objective measures which are taken, the evaluation, they are used as a comparison in the future. The therapist helps to maintain the motivation of the patient, as a person may be less consistent when they are when with exercise, when they are good in a good phase, they may not want to do so much of workout. It's not, we as normal individuals, we shy away from exercise so many times. We don't do regular exercises even to control our weight. So these are patients, these are individuals who are already coping up with various disabilities, various dysfunctions. So what happens whenever there is a period which is during a relapse or after, immediately after relapse? The primary goal is during and after relapse is to regain the previous level of function. A person is 100% normal, functional. There is an attack of the disease, 10% is compromised, a person is 90% uh, normal. So what we do is, as a normal person, as a normal course of human nature, okay, we are functioning, 10% is minimum. So we tend to ignore that 10%. Whenever there is a relapse, so again it reduces. So even reaching that 90% becomes difficult. So it is very important that during the relapse and importantly after the relapse to regain the previous level of function. Because it's a long-term disease, lifelong disease. It can start as early as 20 years, 30 years. So we have to look for the long term. The timing of the physical therapy is also very important during or after relapse. Depending on the severity of the attack, the influence of the medicines, corticosteroids after severe relapse, or the level of function prior to the relapse. So, this timing of the therapy, the amount of therapy, the duration of the therapy is also very important. After initial evaluation, um, fatigue is also to be seen, that what will be the effect of the fatigue on the participation. So this impact has also to be addressed. Again, during and after relapse, safe mobility is important to keep the individual walking or mobile, maybe using a wheelchair or a cane or assisted device, and functioning, optimal functioning of their ADLs, of other activities, of going back to their work, personalized exercises plans, which are geared to the changing needs of the people. And these are the key goals of treatment. Implementing of the adaptive equipments or assistive devices, which may be just temporary till the, if a patient, you want to make a patient stand, they may need a gaiter initially to support the knee. But as the strength of the knee comes back, the patient is able to stand on their own. The individual is able to stand on their own, and the device, assistive device, can be removed. Now, patients and families, understandably, they are very fearful of the impact of the relapse. They're very fearful what will happen if there is a relapse, what effect it will have on their life at home or at work. If they're independent, will they become partially dependent or more dependent? Even at home or at work, will they be able to retain their work? What will be their position in the community? They are going out now, meeting everybody, but most family members may not want to take them to social functions in such a condition. They may find it a burden to take them along. So all these things have to be addressed, and it has to be addressed that the patient may be fearful. The physiotherapist needs to be supportive, encouraging, while providing realistic hope. Don't give wrong hopes. Realistic hopes have to be given and with full optimism. As the disease processes, what happens? There's a progress of the disease. There is an increasing need of the adaptive equipment, which may be grab bars using the washrooms, or shower chairs to having a shower or a bath, equipment for walking, or wheelchairs or walkers. Then many patients and their family members may react very negatively to these devices. They may not want to use these devices. What happens? The physical therapist is the person who will help to persuade and encourage, so that they have an appropriate use of the device, a timely use of the same. What is the use if it is not given on time? So, a timely use of this aid for the benefit of the patient is very important. For these tools to mobility, they are tools to mobility and not obstacles. So please make sure that the patient understands they're just a tool, not an obstacle. It's a tool to their quality of life and not an obstacle. And it allows for safe participation in their activities at home, at work, and in the community. Emphasizes on importance of exercise and physical activity, prioritizing, reprioritizing of the exercises in such a manner that it accommodates the evolving ability level of the patient. What is the ability of the patient at that level? Also, the ongoing issue of MS fatigue. Multiple sclerosis has a lot of fatigue, so it has to be addressed. The therapy should be sensitive to the emotional and social impact of the physical changes on the patient, as well as the family and the caregivers. As the disease progresses, there are cognitive challenges, and while these cognitive challenges can be seen at any stage, while possible at any point of in the course of the disease, it is a more prominent feature as the overall disease progresses. Patient tends to be more forgetful, memory losses are there, cognitive changes can impact the ability to process the information, to learn new and exercises, to new information, to remember those information, including the treatment plans which are given. or the changed, and also the instruction. So these instructions can be given in writing or using technology. Now we are talking about technology. By technology, I'm talking to you and sharing my knowledge with you people. So the technology can be shared with the individual, with our patients, with the caregivers, with the families by using smartphone apps, calendar appointments, reminders, and also the care partner. And these are strategies which has to be used when we are talking about the cognitive issues. The episodes of care may vary from more intense periods when they require actually full-time care, 24-hour care, to people to condition stages when they may have less frequent interactions, or the need of the equipment or exercise modifications which have been addressed. When the disease becomes more advanced, these are the stages where there is a significant burden of the disease, both physically, emotionally, and the cognitive issues. They become non-ambulatory. They have increased risk for secondary health conditions, secondary problems, cardiorespiratory problems. So here, physical therapy intervention may include just seated trunk positioning, positioning of the trunk while sitting, control, stretching, light exercises, maintaining the range of motion, upper extremities strengthening if mobility is limited to wheelchair. So the more focus can be on the upper limbs, the respiratory function activities, the equipment needs, power modality or standing in frames, and also transfer training given to the caregivers, which is very important. It is very important to train the caregivers, which may be the family member or an attendant or a different caregiver. Again, the physical and the emotional demands increase on the family and the caregivers. And this is a very significant phase of the disease because the disease is advanced. The physical therapist should keep on encouraging the family, the caregivers, and also engage in their own exercise activities and other strategies that they use. Discouraging the caregiving form becomes a full-time job. And the role of the physiotherapist extends more to the caregiver during this stage rather than the patient. And there's a need of providing extensive education about use of transferring and safe lifting. This is the presentation which contains my own created material, and I'm thankful for to all of you for a patience and hearing. And I'm thankful for being able to given this opportunity to share what I wanted to do about multiple sclerosis from my point of view. And it is all evidence-based. Thank you, Dr. Shagun, Dr. Dharam Pandey, and Dr. Harpreet.
Very good evening, ma'am. Thank you for this wonderful presentation on MS and how to cope up with a life of MS. And it was very informative from all aspects, I must say, even from the therapist aspect and from patient's aspect. But ma'am, we still, even though it was very comprehensive, we still have a few questions for you from the audience.
Yeah.
And the first among them is there any typical gait abnormality in patients with MS?
No.
Yes, ma'am.
See, each individual has a different area of the brain, and the areas of the brain they tell the pattern of walking. They may be just disbalanced, or they may be a spastic gait or different gaits. Walking patterns differ. So for different individual, it is different. It is the area and the site of the lesion.
Yes,
it may be because of the strength, or it may be because of the lesion which is affecting the balance.
So as such, no identifying gait that
No.
distinguishes MS from other diseases,
No.
like a circumdactory gait in stroke,
No,
they
no.
say,
No.
nothing like that. So it depends on the presenting symptoms and the site of lesion.
Site
and
of
maybe,
lesion
yes.
and the individual.
Right. Ma'am, there was another question, and I think you very rightly mentioned that since the disease is chronic and in a lot of patients progressive, rehabilitation focuses a lot on quality of life. And
Yes.
There is a question on how does sleep become a problem for patients with MS?
Sleep becomes a problem because, see, they are uncomfortable. They may not be able to lie down in a problem. They have psychological issues. They are also apprehensive. And if we have pain, pain also doesn't allow us to sleep. A normal person cannot sleep if they have pain, if they're not
Right.
comfortable. So these patients are not comfortable in positions. And most importantly, when we talk about making them sit in a wheelchair, it has to be addressed. Are they properly cushioned? Are they finding it comfortable to sit? So same
Yes.
with sleeping. We have to make them comfortable. They may have a muscle loss and there may be pain in the one bone touching on the other bone, and they may have pain like that because there's no muscle to support it. So they may need more pillows to be kept under their legs, between their legs, or under their arms.
Okay. Ma'am, and one question which I could not resist asking you, and this would be the last for the presentation, and that was there are some patients also watching it on YouTube today. If you could tell us some home exercises which are easy to follow and do for patients in this time of COVID, because they cannot visit the physiotherapy department. So anything that you would like them to stress on in this period?
Very much. It is one of my favorite subjects because, see, this is a time when not only the professionals are suffering because they don't have their people coming to them for consultation. It is vice versa. The
Right.
patients are really struggling to cope with their disease. They're
Yes.
struggling to cope. But then again, they have the option of using these technologies. They can use this Zoom, the phone, and other images. See, the thing is, they can do normal exercise. We can tell a
Yes.
normal exercise, okay, do full arm movements, full arm movements, full
Hmm.
leg movements, movement of every joint.
Right.
But
Yes.
then a patient in a very weak condition may overstretch. They may
Hmm.
land up with other issues. They may need
Hmm.
more of breathing exercise. And at the moment, the need of the hour with COVID is respiratory. Cardiorespiratory is very important. They
Right.
have to do good respiratory function. I
Right.
am also doing some. I had recently done a live for cancer patients, Anandi Shirus, and for them
Right.
also, for every type of patient now, be it MS, be it cancer patients, be it other patients. Importance is cardiorespiratory,
Right. Right.
and
Uh,
along
yes.
with proper range of movement exercises, proper program, so they can start doing. They can consult a therapist. Therapists are available everywhere.
Yes.
On call, they can consult and have their program designed for them. Maybe they need
Right.
more of leg exercises, like I said, or maybe only arm exercises. But for
Right.
first and foremost, please do good breathing exercises. Good breathing exercises do not mean yoga. I am sorry to
Okay.
say, I'm not in favor of doing breathing exercises by watching yoga videos,
Okay.
because the need is different. The lung expansion. I have recently, yesterday only, I saw this uh, Oxford University, this thing, a research has come which is emphasizing on the need of cardiopulmonary physiotherapists.
Right.
So very evidence is there. So this has to
Right.
be done. They have to do breathing exercises by mobilizing the rib cage, by strengthening the respiratory muscles. So that is individualized program.
Right. So this is what you stressed also in your presentation, that
Yes.
the rehab programs have to be individualized and tailored, and because the patients are in different stages of the disease and with different impairments, so it is very important that individualized programs are tailored. And a message to all the patients who are watching is that by any means try to contact your physiotherapist, consulting physiotherapist, for upgrading your program regularly through any means of digital media.
Yes, here I would want to say one thing. Please, it is emphasized, you don't have to go for regular consultations. No one says go every week. No one says go every month. But yes, it has to be followed on. Maybe once in
Right,
3 months, or maybe if you have more relapses, sooner or later also. But it has to be continued.
right, right, ma'am. Thank you so much for being with us, and it was very informative session for all. And we would expect you keep sharing your experience with all of us again and again. Thank you, ma'am.
Thank you. Thank you very much.